Okay, this morning we're going to talk about respiratory assessment. And since the majority of pediatric patients, their chief complaint is respiratory distress, whether it be primarily from that system or not, it's an extremely important clinical ability that we all need to work on and become very good at. I'm trying to break it down so that it's something that you can think about each and every time you approach a patient. Basically, what I like to think about it as is 5 parts, okay? The first part is the respiratory rate, all right? The second is air exchange. The third is saturations. The fourth is retractions. And the fifth is adventitial sounds. Okay? Obviously, as clinicians, we ideally like for things to be very objective. All right, you know, quantitative, we want it to be something that each person could go in and look at and end up coming to the same conclusion. Sometimes that's difficult to do when you're talking about something more subjective. But obviously some of these things, like respiratory rate, is clearly objective. If I count the respiratory rate, someone else comes in and counts the respiratory rate, we should get about the same number. Your pulse ox from your saturations is fairly objective, unless your pulse oximeter is having issues. So everyone who looks at the same patient should get the same result. However, when we talk about things like retractions, obviously that's not something that lends itself to being quite objective. So, you know, what do we do? What do we do when we want to try to make something objective that is subjective? We put it on a scale, okay? Like we have the pain scale, and we have, you know, other scales. What I usually like to do is you can either make this a word, an adjective, or you can assign it a numerical value. But I think it's just easier to go with a description. All right, so if you talk about retractions as being, you know, 0 or none, mild, moderate, or severe, okay, then it helps to kind of quantitate something that is a qualitative thing. And that helps us when we follow the patient, all right? If someone is first described as having severe retractions, you do an intervention, you know, such as an albuterol neb, and then you go back and reassess the patient afterwards. You know, hopefully there's some improvement, and adding those adjectives or those modifiers helps us look at the patient over time and see what direction they're going in. All right? So retractions can be described as, you know, like I said, none, mild, moderate, or severe. This is subjective. Okay. The other thing that needs to be placed on a similar scale is air exchange. All right? When you approach a patient and look at them, and you use that thing that hangs around your neck, all right, called a stethoscope, what are you really after, okay? When you approach a patient and you look at them, I mean, what do we use as a gold standard? We use an arterial blood gas as the gold standard for assessing somebody's respiratory status, right? So when you look at a patient clinically, what you're really doing is trying to apply your physical exam skills and your understanding of pathophysiology and come up with a PO2 and a PCO2 that this patient has. And I know we don't think about it that way, but that's really what we're doing. So you are trying to clinically look at a patient and develop your sense of what their respiratory status is for both oxygenation and ventilation, and come up with numbers in your head or a range that lets you know that this patient is fine. You're a little worried, you're more worried, or this patient's not meeting the standards which are acceptable without some type of intervention. And that's really what you're doing. So when you listen, the first thing that you should really assess, all right, when you are doing a clinical assessment, not looking, not counting, is the patient's air exchange. And again, it's something that's subjective, all right? But what we can do is apply the same sort of scale, all right? The air exchange can be graded as none, meaning, very poor, okay? It could be fair, it could be good, or it can be excellent, okay? And once again, that just kind of allows us to take something that is, very qualitative and assign some sort of adjunct descriptor so that, my exam, when I leave, at the end of my shift and turn it over to the next person, that they can, then still judge whether this patient is clinically improving, worsening, or staying the same. All right, so air exchange is extremely important. And many times when people listen, when the first thing they want to say when, they're speaking, they're giving either a sign out or report or whatever, is they want to go straight to adventitial sounds, okay? And if you listen to other people talk or you listen to your peers talk, listen and see if this is true, because everybody wants to say, well, how's his respiratory status? Oh, well, he was wheezing, really, inspiratory and expiratory wheezes, diffusely, all right? That shouldn't be the first thing out of your mouth. The first thing should be your assessment of their air exchange, all right? Because the air exchange tells you the patient's physiologic status, all right? It tells you, essentially, you're assessing their adequacy of tidal volume and their adequacy of ventilation. And that is much more important when you're dealing with a patient's physiology, which is what we do, versus an adventitial sound, okay? So let's talk about adventitial sounds. And what the heck is that? All right, we're talking about things like, as I said, wheezing. Okay, this isn't happy again. There we go. We're talking about wheezing. We're talking about stridor. We're talking about crackles. We're talking about coarse breath sounds. We're talking about decreased, all right, or absent breath sounds. Those are the biggies, okay? Once again, air exchange tells you about your patient's current or, their physiologic status, all right? What do adventitial sounds help us do, okay? Think about it. We're talking about wheezing, stridor. What do those things represent? Crackles, okay? Adventitial sounds help us make a diagnosis as to why the patient's clinical status is what it is, all right? If somebody's wheezing, is your first thought that they have pneumonia? Okay, no. In our mind, we break that down, and we're saying if we're wheezing, then you've got a small airway obstruction, all right? And that leads us to a diagnosis of, something like bronchiolitis, RAD, asthma, foreign body, okay? Something that's obstructing the air passage of in our small or larger airways, all right? So that's